again, clear to auscultation for the right middle lobe. Now I'm going to move to cardiac. For this portion, you can now relax and breathe normally. It's actually easier for me to hear your heart sounds if you're relaxed and just breathing normally. Are you okay to continue?
Yeah.
Okay. So for cardiac, I'm going to start by listening to your heart valves. I'm going to start by finding your second intercostal space. So your clavicle, right below that is the first intercostal space. The rib, second intercostal space. Right at the sternal border is the aortic valve. Coming across the sternum to the left second intercostal space is the pulmonic. Moving down one rib space into the third intercostal space is Erb's point or second pulmonic. Coming down about a space and a half and starting to move to the left will be tricuspid. And can you raise your left arm in the air? Thank you very much. Fifth intercostal space. Midclavicular line is mitral. And then I'm going to flip to the bell and come back up. I use the bell because sometimes I can hear certain murmurs better with the bell. They hear duller pitch sounds. Okay. Tricuspid. You can put your arm down. Second pulmonic, pulmonic, and aortic. All right, during my auscultation, I was able to hear S1 and S2. I hear S2 best at the aortic and pulmonic, and S1 louder at the tricuspid and bicuspid. I also want to point out that the mitral valve is where I would listen for the apical pulse, and it's also where I would palpate for the PMI. Okay. I didn't hear any abnormal heart sounds like S3 or S4, or any abnormal heart sounds like murmur or rub. So I'm going to have you lay down, get comfy, put your head on the pillow. And then I would go ahead and I would listen to these cardiac sounds again because some heart sounds are positional, but because I did them correctly, I'm going to skip that. And I'm going to move to the arteries. So I'm going to be starting by listening to your carotid artery. If you can point your chin towards the ceiling, and I'm going to listen to your left carotid and right carotid. And I hear breath sounds, but I do not hear a bruit, which is what I'm listening to rule out. Could you point to the end of your sternum? Sternum.
Oh, my bad.
Thank you. Okay, and right below that is the aorta. Again, listening for bruit, which is a turbulent sound in an artery. Left renal. Right renal. Point to your belly button. 45 degrees iliac, left iliac, right iliac, and stating femoral. At all of those locations, I did not hear any bruits, which is a normal finding. It is safe to palpate your carotid since I didn't hear a bruit, so you're going to feel my fingers now on your left side of your neck, first palpating the carotid for pulse or strength and symmetry, excuse me. And then the other side, one at a time on the carotid for safety. Very good. Those are both +3 at the radial pulse. I can do together. Those are both +3. Stating femoral, stating popliteal, posterior tibialis is right behind the heel. I don't know if you have very thick socks, if I'm going to get that lucky. Oh, I do. +2. Those are good. Okay, and then dorsalis pedis, we're going to have to pretend on those, would be a +2. All right, and we're going to finish. Okay, so when looking at the different valves of the heart on a skeleton, it's a little bit easier to understand and visualize. I recommend on your patient starting by finding the patient's clavicle and then kind of using your fingers to fall off the patient's clavicle into the first intercostal space and then into the second intercostal space. Once you find this first landmark, then you can kind of slide your stethoscope across the chest to the other landmarks without actually having to count rib spaces. So at the second intercostal space, right here at the sternal border on the right-hand side of my patient is the aortic valve. Then I'm going to take my stethoscope and I'm going to slide across the sternum in the second intercostal space to the left sternal border, and this is the pulmonic valve. Then I'm going to move straight down one rib space approximately into the third intercostal space, and this is Erb's point. Remember that Erb's point is not an actual heart valve, it's just a place where we're able to hear S1 and S2 sounds equally. Then we're going to move down into the fourth intercostal space, starting to move just slightly away from the sternum, and we're going to listen for the tricuspid valve. And then we're going to move into the fifth intercostal space over at the midclavicular line, and we're going to place our stethoscope here to listen to the mitral valve, which is also the point of maximum impulse on palpation, and it is also the apical pulse. After listening to the valves on the way down, then you're going to flip your stethoscope over to the bell and come back up. So again, we have the mitral valve at the 5th intercostal space, mid-clavicular line, then moving to the 4th intercostal space, slightly moving back towards the sternum for the tricuspid valve, then at the sternal border in the 3rd intercostal space for the Erb's point, then into the 2nd intercostal space for the pulmonic valve, and then across the sternum to the aortic valve. When auscultating the central arteries, a couple things that are important to know. First, I want you to take a look at the aorta. The aorta is this very large vessel that runs from the heart down to perfuse all of the abdominal contents and lower extremities. When you're listening to the aorta, the proper landmark is to find the diaphragm, okay? Ask the patient in class, you can ask them to point to the end of their sternum or their xiphoid process. Just below that point is where you're going to place your stethoscope for the aorta. After listening to the aorta, you're going to move down to listen to the renal arteries. As you can see, the kidneys are here. However, we're not listening to the kidneys themselves, we're listening to the renal arteries, which are these very small arteries here branching off of the aorta. So after you have come down from listening to the aorta, you're going to move your stethoscope on your patient's abdomen down just about an inch and then out an inch. Okay, so here we have our patient's right renal, and then moving back to center and then an inch off center to the left, we're able to listen to the right renal. After we listen to the renal arteries, we're going to move down to the iliac arteries. The best way to find the iliac arteries is to ask the patient to point to their umbilicus. Using the umbilicus as a landmark, well, you can't see the umbilicus here, but you get the gist. You're going to draw an imaginary 45-degree line from the umbilicus to the iliac artery. Okay, so here's your iliac artery here, and here's your iliac artery here. And those are going to be located in the lower quadrants of the abdomen. And then last is the femoral artery. The femoral artery sits down here in the groin. Okay, so we have iliac and we have femoral. Femoral is located in the actual groin, and so for class that's a little bit invasive, so you'll just point kind of over your patient to the direction of where the femoral artery is located, but it will be important for you to know. So just as a review, again, when you're looking at proper location for the abdominal arteries, ask your patient to point to the edge of their sternum at the xiphoid process and place your stethoscope directly below it in the center for the for the aorta. From the aorta, move your stethoscope just down slightly and just slightly to the left for to the right for the right renal, and then to the opposing side for the left renal. Then use the umbilicus as a landmark and draw a 45-degree angle to the iliac artery, and then same thing for the opposing iliac artery. And then you will simply state femoral, which is located in the groin.